Today we are going to discuss something different and which is also very important from various aspects. And no person other than Dr. Dongre will know it better because he also happens to be the CEO of the critical care hospital. So I'm sure that he has been an adjudicator many times and has, as a third person, has observed the fallouts of both good communication and poor communication in healthcare system. So we know that to execute anything, any good work, two sets of skills are very important. Whether it is medicine, whether it is engineering, whether it is politics, whether it is business, two sets of skills are very important. One set of skills are the hard skills. Hard skills are the one which are acquired through repetitive training, gradually, over years, physically, and which is easy to measure. For example, in an ICU, you know that there are certain skills like hand hygiene, 5 moments of hand hygiene. This is an acquired habit, which one acquires through repetitive exercise, learning, skills, and gradually one moves on and becomes proficient in it. The WAP bundles, the care of urinary tract infections, how to prevent urinary tract infections, the use of monitors, etc. So all these are part of our hard skills. In addition to them, of course, these hard skills are very important for the sake of successful execution of your work. But equally important are also another set of skills, which are the soft skills. So soft skills are slightly different from the hard skills is that they cannot be measured so easily. They can be perceived. They can create an impression, but it is not possible to objectively measure each and every aspect of the skills so easily. For the nurses, there are several such soft skills which are very important and which take its shape in execution of their work or task in a proper way. But the foremost of this is communication skill. So whereas communication is something which is important for all healthcare workers, every member of the team, for the nurses, it is particularly important because they are the companion of the patients for a much longer time in any hospital who is admitted in a healthcare setup. So why is communication so important in healthcare? And not just in healthcare, but it is important in everywhere, as I said. But in healthcare, there are specific reasons why it is very important. Because, and Dr. Anand sir will also agree here, that patients' perception of the quality of care is highly dependent on the quality of their interactions with the team who is treating them. So whenever a patient is happy about the care, he or she is indirectly happy because the communication with the team taking care of the patient or of the relatives of the patient has been good. So perception, that is number one. And the second important reason is that if the communication is poor, it can lead to various negative outcomes. Negative outcomes means something which is not expected. If you expect recovery, you are not getting recovery. But why it is so, and what are examples? There can be several such causes of negative outcomes. There can be discontinuity of care. The patient might not feel interested in continuing care under you or getting the care at all. There can be compromise of patient safety. You know it very well if the nurses are instructed to ask patients not to take any particular medicine a night before for some reasons, and they do not communicate properly, and the patient takes that medicine the night before or the coming morning, some of their tests have to be delayed. So this is the very common example. So what they are supposed to do. If they don't do, that compromises with the patient safety. Similarly, there can be inefficient use of valuable resources because of lack of communication between the team members. The use of resources that needs to be used judiciously or only in selective cases can get overused if the communication is not proper, or it is poor, or there is some barrier between the communication. And of course, dissatisfaction in patients is a negative outcome that nobody would like nowadays, be the government sector or be the private sector. And overworked physicians. Overworked physicians, if there is a poor communication, then in order to compensate for the deficiencies, someone has to work more. I remember long back, one of our ex-dean was telling in a meeting that everyone in an institution is important. All are pillars. Some are weak pillars, some are strong pillars. But weak pillars are also necessary because these weak pillars make the strong pillars perform their work more effectively. So therefore, in communication also, if there is a communication failure, to make up for that failure, someone has to do more work. And I'm sure Dr. Anand has also taken that role of trying to do some more work in the case of such failures in real time. So effective and efficient communication is crucial in healthcare system. Therefore, communication, if we think it in just in vocabulary terms, it is not a mere form of information exchange. It is not a mere form of information exchange. It is an expression of relationships among individuals and their natural environment. Why it is an expression of relationships? You know so many people. If you see them, they interact with you, talk to you. But suppose tomorrow someone's mother is sick, someone's wife is sick, someone's son is sick. Will he react in the normal way with this? He will not. Why? Because that is his not natural environment. So it is an expression of relationships among individuals in their natural environment. And it is not just verbal. There is more to it. There are a lot of non-verbal pursuits of communication. You know, in English, there is a saying that actions speak louder than words. You may not say anything to a person, but just by your body language, you can send him very strong signals that he perceives strongly or that arouses a reaction in him. So communication is both verbal as well as non-verbal. It involves individual rights and expectations. You know, in any healthcare setup, in critical care, when the doctor says the physician that the rest sister will explain you once you go to the ward, or I will inform sister in the ICU once you reach there, they will explain you. The patient has naturally a lot of expectations from the team or from the doctor or from the nurse, whosoever is. And it also involves the rights because he is the person who has the right to such information. And communication aims to fulfill shared decision making. You know, earlier it used to be a paternalistic approach in healthcare system. मैंने जो बोल दिया वही होगा. Whatever I have said has to be followed. Not too many questions need to be asked. But times have changed, and so have our acceptance, and so have the norms of medicine have also changed. So in order to fulfill the principles of shared decisions, there also communication is very important, or else the decision will get delayed. And if decision gets delayed, then again the patient's health gets affected. There are effects on the cost, etc. So good communication guarantees autonomy for decision making. If your decision making has to be appropriate, your communication must be good. So you know that there are various forms of communications. I am not going to impress upon all those communications like a management school. But whatever we need to know in an ICU, we are mainly faced with the verbal communication. Of course, the non-verbal communication, written, the visualization, all these things have their own role and importance. And probably they have as much as importance as verbal communication. But verbal communication is the primary forum or the primary means by which we communicate. And therefore, this is the aspect on which we can have a discussion today. Now, again, Dr. Anand will be probably in agreement with me. Yes, Vinny D'Souza, I have seen you have raised your hand, and I will take your question very soon. That what are the core principles of patient satisfaction? You know, patients always have an expectation that they will get an opportunity to tell their story, and which is fair enough. When healthcare teams this problem seriously, explains clearly, tries to understand the patient's experience in the course of illness, then they are more satisfied. When the patients are able to express their concerns and expectations, they are more satisfied. When their social and mental functioning is acknowledged, their decision making is enhanced, they are more satisfied. When the length of healthcare visit increases, they are more satisfied. The clinical team in which the clinician works is good, they find it satisfactory, they are more satisfied. When the healthcare team initiates referrals, if the patient needs any, relieving them of that opportunity or of that responsibility to themselves go and search their physicians, they are more satisfied. When they can get the same continuity of care within the same healthcare system, they are more satisfied. And when they're treated with respect and when they're invited to partner in their decision making, their dignity is preserved, they're more satisfied. Now, you know that every time all these aspects are useful, but all of these aspects may not be possible to be satisfied to the extent a patient may wish to. In an ICU, the time spent cannot be to the patient's satisfaction if it is a busy COVID ward with patients coming in at random. But one thing which can be constant, or the core element which can always be preserved, is the communication. Even if it is brief, it can be suitably tailored so as to understand and explain all the concerns, all the problems clearly, so that the patient is satisfied. Reference may not be required, or even if some required, some hospitals may not have all the departments, so it may not be possible to satisfy them. But communication is possible. Communication is not a one-man show. Communication is entirely a team game. So communication is one of the core elements of patient satisfaction that can be satisfied substantially in all cares, in all ICU setups, in all places, big or small, private or government, medical college or a district hospital. Now, obviously, I will take the question a bit later when I go through the main principles, because some of your questions might get answered during this course only. So I will just go through a few more slides, so there should not be any repetition. Now, why ICU represents an area of difficult communication? Firstly, because admission in the ICU is often sudden and unexpected. I'm not going to say that it is always sudden and unexpected. Many a times it so happens that ICU admission is also known to it. But much of the times, 99 out of 100 times, it is sudden and unexpected. Relatives and patients are often unprepared that their near ones is going to land up in ICU. Sometimes they're prepared, but sometimes they're unprepared. Unprepared both mentally, physically, financially, etc. ICU is often perceived to ordinary people as a strange and threatening environment. So many different gadgets, instruments, beeps, sounds, all patients spread over an area, some with tubes, some with lines and this and that. There are barriers to normal verbal communication that we see in the ward or in other areas of the hospital. That is, patient is intubated, patient can't speak, patient is raising his hand, patient is trying to indicate something which the workers are not able to comprehend. Because of the use of sedatives or because of muscular weakness, because of the illness, even if someone tries to elicit information during the communication, it may be apparently very difficult, very common. So that the nurses are struggling, even the doctors, young doctors are struggling to gain some important inputs or take some important information by conversing with the patient because of these drugs. So in contrast to other areas, ICU represents an area where communication failure can occur because of lot of such reasons, which pose an inherent difficulty in information exchange and communication facilitation. So if you try to observe some of in the times of the terminologies that has been used for ICUs and other areas of the hospital, in other areas of the hospital, what we call as consultation, because it is a 1:1. The patient of diabetes, not on drugs or on insulin, not getting controlled, kidneys showing changes, needs a detailed discussion with you, consultation, 1:1. In critical care, because of obvious reasons, it becomes a family meeting. In other places, what is a patient-centered care? In a critical care, it becomes family-centered care. Families' wishes are important. Families' finances are important. Families' decision for a lot of procedures are important. In other areas of the hospital, it is of gathering information directly from the patient based upon the clinical course of illness. In critical care, the equivalent would be use and reliability of the surrogate history. Why surrogate? Because the patient himself is not in a position to narrate his entire thing. In a routine care, in other areas, it is important to discover the patient's perspective. In a critical care, we have to deduce the patient's perspective from the available information. In person, with his relatives, near and dear ones, from the papers which are available and which are available with us, which we have to judge. In other cares, we have to be involvement of decision making with the patient only. Here in critical care, we have to seek an agreement. By agreement, I mean a consensus and shared decision making. In other areas, it is a development of a doctor-patient partnership, because probably in many patients have been knowing the doctor for years. In critical care, it is negotiating a mutually acceptable plan, because the patient who has been shifted might be seeing you for the first time, and his doctor may be a physician with whom he has been consulting for last 10 years. So when it comes to treatment, it will be. So from all these points, communication is very important in an ICU, because the traditional structure of patient-physician interaction is vastly altered in an ICU when a patient is there. I can take at this stage, I think that there were 2 hands were raised. Yes, Winnie D'Souza, you can unmute yourself and ask your question. Winnie D'Souza, you are one of the listeners who have raised the hands. And if you are not, can't unmute yourself, then I will request Neil to help in unmuting her so that I can take that question.
So please hold on, sir. I'll just.
And both me and Dr. Dongre will try to answer. 2 persons have raised their hand. One is Winnie D'Souza and another is Ashwini Lakade. So if Winnie D'Souza can't be unmuted, Neil, I will request you to unmute Ashwini.
Sir, Ashwini is already, so she just needs to unmute a mic and speak.
Okay. Ashwini, you can unmute your mic and ask your question. if you have raised your hand and you have a question to ask.
Even Vinny can unmute her mic and raise the question.
Yes. First, we have first Ashwini, then Vinny. First Ashwini, then Vinny. Ashwini, if you don't have any question but just have mistakenly raised your hand, you can say that it's not taken as any, it is a lack of communication. So don't worry. Vinny D'Souza, your time. Yes, Vinny D'Souza, please unmute your mic and ask your question.
Hello.
Yes, ask.
So regarding in the ICU only, I was wanted to ask about the communication.
About the?
About an ICU patients.
Yes.
Because they cannot communicate each other because with the ventilator
Yes.
everything.
Yes.
So how we can go about it?
Yes, yes. We are coming to that.
Okay.
We will talk about all those things in the subsequent, because
Yeah.
now we have just begun. We are gradually we are going inside the forest. We are still on the outer zone, safe zone.
Okay, sir.
Can I?
Yes, yes.
Can I interrupt? Professor, just a moment here, where she has talked about a very good questions. There are two types of patient in ICU, one communicable, other non-communicable. Suppose whenever you get a patient first on day one and he's hypoxic or you want to put an oxygen, then you need to start a rapport with him. You just don't go and rush to put an oxygen over his face mask. In what I have found that during our practice, it makes patient more hypoxic or more he becomes angry that somebody he doesn't know. You say that I am putting oxygen to your face and you are going to have it and you feel better. See, language is one barrier, communication is another barrier, and having a rapport with the patient is the first barrier you should cross. So you must tell that, my dear Mr. So-and-so, you regard the patient as your guest, and those who are those are the patients with whom you are going to communicate well. You must tell that what is your name. I mean, say I am Shivani or I am Vinny. I am going to put this oxygen on your face so that you will feel better in a few moments. And this is how you start communicating with a communicable patient in ICU. Rest to the non-communicable, I think Professor will go and talk to you more about it, or we can discuss it afterwards.
Yes, yes, absolutely. Professor. Yes, sir. Am I audible? Am I audible? Yeah. Yes.
Yeah, go ahead.
I think Vinny, we are touching every, and as Dr. Dogre has already pointed out, that these are the ones. Now, a lot of studies have found out some of the limitations. What are the limitations that studies have found out? Studies have found that 95% of patients lacked decision-making capacity at the time of end-of-life decision. And no, this is not India, this is Europe, this study is from. And patients' wishes were only known in 20% cases, 1/5 of the cases only. And this is not a very old study, 2005 is only 15 years back. Even if it is not 20% now, it may be 30 or 40, but not more than 50. Also, in 2/3 of the cases, the end-of-life decisions, which are so important decisions for any patient, were discussed with the family in only 2/3 of the cases, 68%. In a French ICU, more than half of the relatives of admitted patients had failed to comprehend the diagnosis, prognosis, or treatment of the patients when they are interviewed after routine family meetings. So if it is occurring with your ICU or my ICU or some other adjacent ICU, don't think that something uncommon thing is happening. It is happening everywhere. It is something where scoring 100% is next to impossible. It is only our attempt should be to improve, so that all those principles which I had shown you earlier, the principles or the way of patient satisfaction, they can be fulfilled. So these limitations have been seen elsewhere also. Now, another consequence was, what is the consequence of poor communication between team members, nurses, technicians, junior doctors, senior consultants, lab people, etc. There are errors related to medication, almost half, 42% of the incidents. Incorrect or incomplete delivery of the care. You have been told to deliver one medicine, you have given something else. Equipment failure. You have been not identified or not checked an instrument before, or someone before the rounds have not told you that this ventilator is not functioning, and you have tried to connect a malfunctioning ventilator to the patient, and suddenly things seem to be out of control. You ask the previous person, no, I have seen, I have written it, that not, and pasted a sticker, but the person, you have not told him, so he has not seen that sticker. These things have happened in our real life. That's why I'm suggesting these as examples. And of course, lines, tubes, and drains. So many times, without checking the central line, something gets pushed, and you realize that the line is out of place. When you do a X-ray or somewhere, the blood is not aspirated. Drains, you forget to remove the clamp, or at times against the gravity, and you will notice that the column is not moving. So if it is not moving, you have not communicated. Events involving lines, tubes, and drains, they are most likely to cause patient harm because of poor communication between the team members. More than half of the cases. Yes, Anand sir, you want to say something? This is important.
Yeah, just very right. Rightly, you have pointed out it is drugs which are miscommunicated very often. I tell you the example how bad things go. A born patient who was admitted with us was vomiting. So the consultant on the round said, just give her injection ondansetron. The nurse was little far away. So what she thought that he has asked me to give Pavilon, because at that time pancuronium or Pavilon was quite in use. And you can find out the horrifying sequence we had, that she gave 4 mg of Pavilon instead of ondansetron, and the patient got intubated. The patient was almost conscious and spontaneously breathing, but thank God she has recovered very well after that, because the consultant was out. He comes to know that yes, she has been given pancuronium. He intubated her, and then afterwards, after 6 to 7 hours, we could extubate her very well. So this communication error is very important. Unless you understand what is to be done, you can ask again. So the communication between team members has to be very, very clear and crisp, and it should be 100% clear that you want to give, you have asked me to give this drug. That
Absolutely,
is one.
absolutely.
Second time, hands off. Hands off. Whenever you take your over from your colleague, from another nurse. So instead of taking central line, even people have taken a catheter, or instead of catheter, people have taken a central line. So this miscommunication always harms the patient. Remember this. Go ahead, sir.
Yes, absolutely right. And as Dr. Dongre has said, I'd also like to tell one more thing in this regard. As many team members are coming from different setups. So if someone is telling Pavilon, the other person may have come from a setup where he is used to calling Pavilon by some other name. It happens. In Pavilon, it is, so there are a lot of other examples we can say that so there may be lack of communication, because with the same thing, same drug may have 2 different colloquial names in 2 words. It may have been called as PAV. So when you say Pavilon, it may not strike immediately that it is PAV and Pavilon are the same thing. So likewise, because the team members are assimilated at times from different parts of the country, from different setups, so there is often a difference in their understanding or in perception. Often it is said that 57% of the errors were related to problems with verbal or written communication during routine care. We all know, we all see that our nurses, they write everything during handover. They also give verbal handover. Sometimes we don't check it, but when someone points it out, we also found that there is discrepancy between what they said and what they have written. Discrepancy because what they might have told is different from what they have been written. Why? Because their writing may have been done much before in order to save time during handover, and something must have been changed by them which has not got corrected. So these are the errors which are considered to be a part of communication errors. 37% were related problems with verbal or written communication during handovers. 21% were related to team structure and leadership. 6 were related to problems in verbal and communication during crisis like CPR, etc. So that is why you know that the consequences of poor communication between team members can lead to catastrophic consequences to the patient from all perspectives, whether it is a medication error, whether it is an equipment failure, whether it is taking out of the wrong lines, etc. Therefore, we need to have some tool to assess the communication skills. So what are the tools available? Whenever you see that there are such a long list of tools available, you have to realize that basically there are no tools. Why so? Because as I said, it is something which is very difficult to measure. Soft skills are difficult to be measured objectively, but they can be perceived subjectively with a lot more precision. So whether it is team, whether it is T-notches, whether it is steps, whether it is Oscar, so all these are tools of assessment of communication skills in healthcare employees. But the number of tools which are designed for non-technical performance, unfortunately, their validity is not adequate, or we cannot trust them to be adequately validated for all our ICU patients. So for ICU patients, we take a wholesome view of these tools and develop our own tool, or rely on our perception. Perception is a very, very important tool of assessment of communication skills. If one can put himself or herself in a neutral position and try to judge both sides of the story. That is what I mean, that if you ever, as a patient side, if I am ever patient and I have to go into the ICU as a patient's relative, I will be able to judge many aspects of communication skills of the healthcare workers in a much better way. So what do we do then? The most easiest and the most accurate part is to collect feedbacks. Feedbacks from the patients, relatives, or patients' attendants, when, after, during the time of discharge, during any time. It is best, most people do it at the time of discharge. They collect responders about their perceptions, because on the basis of those perceptions, you can have a plan on what improvements in communication skills are necessary for the staff who are under your care. So all these questionnaires that are used commonly, that are based on certain inputs, processes, and performances that take into consideration a lot of factors. We are not going to touch upon that, but just we can take this lesson that questionnaire feedback from admitted patients can help you gain valuable insights to judge the communication skills that are prevalent and understand the deficiencies that exist. So 3 participants are raising their hands. So Neil, can you please unmute these 3 participants so that they can ask their questions? Pooja, first to ask is, you can ask. Pooja, unmute yourself and ask. If you have any question to ask Pooja, you can ask. You have been unmuted and I am waiting to hear your question. Unless you have raised your hand by mistake. Neil, can you unmute the other questionnaires also?
Yes, sir. I have unmuted sorry, Rushika can unmute herself and speak, sir.
Whoever wants to ask, we are waiting. You can unmute and you can ask. Dr. Dongde will answer your question, if there is any.
Mr. Sagar, you can unmute yourself and ask the question.
Ruksar Nevarkar, you can also ask if you have any question by unmuting yourself. Rukshar.
And language will not be a problem in case you want to commute in
You
any
can-
other language, Hindi or
Yes.
Marathi,
You can do
or
that. You are free
whatever.
to do that.
except South Indian language, which either both of us don't know.
Yes.
So you can communicate very easily in your language also.
अगर आपने हाथ उठाया और मन में कोई सवाल है, लेकिन ऐसे हाथ मत उठाइए बिना सवाल के. If you
There are four hands raised.
5 now. I think if we just keep on waiting, nobody asks, so we can.
Can we ask Neil to write their questions on the chat?
Yeah, they can put their questions in the chat box, or if they have any.
Okay. Anyways, you can mute them once again, Neil. I think they better put their question in the chat box so that we will take them appropriately in between once that is ready. So, as we were talking about the problems of poor communication between the patients, poor communication between staff members, then the obvious question which follows these answers, then what are the barriers for good communication in ICU? What prevents? We know that ICU is a challenging environment, we have discussed. But in spite of that, if my communication skills are good, if patients' perceptive skills are okay, reliable, then what are the barriers of good communication in the ICU? There are often logistic issues, which these are all common scenarios. Surgical team rounds before family is present. Sometimes the entire team is not there. ICU doctors are there, some surgeons are there, some not there. Not all parties are present when meetings occur. Other support resources pass. So this is not relevant, so we will not talk much. Not enough time during the meeting, because after the rounds, everyone is in a hurry. So if someone has come to see their patient in the ICU and they have to attend their OPD or reach their OT, they are in a hurry to finish their talk and rush. Poor availability of doctors or family for a meeting. Multiple decision makers in a family. So the family, sometimes it is not clear that who is going to be the surrogate, whether the brother or the son or his wife or his parents, and neither they are clear about that. Multiple decision makers, surrogate decision makers, or who is the actual person? He is not there, rest everyone is there. Lack of unbiased person, patient cannot participation in conversation. So all of these are logistic issues that becomes barriers for good communication in ICU. Next, there are occasions when there is discomfort. Why there is discomfort? Because physician discussion with nurses and families are inconclusive. If physician has suggested something and the patient is not decided, so the nurses are also not sure that what they will tell, whether they will wait for the physician's instructions or continue with the instructions that physician had told them before, or wait for the concurrence of the patient's relatives. Family members do not want to hear bad news and avoid the meeting, that things are not working, the inotrope support is increasing. Difficult to say whether he will be able to make up. Maybe he'll make up today or coming days, but the patient's family members are not in a position or not willing to hear a bad news. Prognoses are unrealistic and often portray small victims. So unrealistic prognosis, again, one very important aspect when patients or other faculties of other departments are admitted in the ICU many a times, cancer patients, etc. They sometimes feel that patient is probably becoming better, and their physician doesn't strongly prognosticate on the outcome, on the poor outcomes, so that there is a dichotomy in the patient. ये तो बोल रहा है कि ठीक हो सकता है, he is saying it is not that good. So what is the actual scenario? Unclear whose role it is to discuss the prognosis. Poorly defined goals of care even prior to surgery. Sometimes it so happens, you have seen that patient is planned for surgery, but the goals of surgery is not clear, because if they do a staging laparoscopy and find nodules in the peritoneum, they will plan one type of surgery. If they find everything is clear, margin is clear, they will plan another type of surgery. So all these plans are subject to a lot of observations that are likely to take place at that point of the time. So discussion about this is very difficult, that if A happens or B happens, etc. I'm sure Dr. Dongre will also agree that this situation is common in their setup also. And perceived lack of skill or training, physician discussions are rushed. Families are often not given adequate time to ask questions. Communication is often done last minute. Very common. Means we used to hear it, although it is not happening now. That in earlier days, patients was undergoing angio. At that moment only, that please sign. Their patient needs to be put to stents. And now or never, if not now, patient will become serious. So patient had come for angio, and probably patient is not sure or neither have the money also. And it is too quick a decision to do everything, arrange, give consent, and deposit the amount. So these are some of the practical examples, which we have been seeing over a long time. There is no accepted protocol about when and what to communicate. This is also a very serious fallout about patients whose prognosis is not clear upon arrival in the ICU. For example, a patient of CA esophagus with liver metastasis can have a leak following surgery. Now, the primary purpose for which the patient is brought to the ICU so that the leak gets sealed either conservatively or through a reduced surgery, and the patient is shifted home. But nothing has to be done with the liver metastasis, because that is anyhow, that is a stage 4 disease. So the ICU physician sometimes becomes confused, there is lack of training to say, he thinks that no, this is stage 4 disease, prognosis is poor. So what prognosis is poor doesn't mean that patient will not be able to return home if the leak for which patient has come to the ICU gets sealed, whether by treatment or without treatment. So in such cases of perceived lack of skill or training also act as barriers of communication. Do you have such examples, Dr. Anand, in your personal experience? Unmute, please unmute. Please unmute first.
That's true, Professor. Many a times we come to a situation where just a consultant of another specialty has talked to the relatives, and he has given, has broken bad news to them that this could be possible. And then suddenly someone else, say from any member of the team, says that, okay, patient is fine and he is okay. And next moment you find that the patient gets intubated. So these are the situations. Surprises in ICU are to be avoided. And in this situation, you must feel, I feel that you should always attend those communications with the relatives whenever it is happening inside or outside, just outside the ICU, so that you can understand what the consultant is telling them. Second thing is the language barrier, which often for you in ICU, working in ICU, mechanical ventilation or prognosis, bad prognosis or encephalopathy, these are all new, not new terms. You know what they mean. For another world, your world is different. The another world is there where these terms are not normal. So you have to explain them in their words. These are the two very important aspects when you communicate with your patients.
Absolutely. Absolutely. When we enter into IT and they talk us about the cloud computing, we are also, it is a different environment for us. We also don't understand half of the terminologies. And we also want that they should explain those terms in a brief and a simple way so that we can also understand the crux of that. So the same thing applies for them as well. So there are also other barriers. That one is the fear of conflict. Now this conflict is again a very different, separate and a very unique issue. When conflict will break, on what grounds, nobody can predict. It is nobody can predict like which family members of a contact of a COVID will develop serious illness or who is less serious, like that. Fear of conflict, that many a times fearsome situations do happen, but it is resolved so nicely and both sides go back happily. And at times we realize that such a good relation between patients, relatives, and the ICU team, treating team of doctors. And suddenly for a very simple or a very trivial issue, there is such a severe conflict that the entire hospital becomes have to get involved. Now, different opinions about prognosis between care providers. Now, this is something which causes conflict. If physician A tells something, physician B tells something, physician C tells something, then that brings in conflict. Now, if that is happening, as such, nurses are unable to do anything because they cannot give an opinion above everyone. But what practically I have seen good nurses and what I advocate is that they can encourage the patients to go and talk to their primary physician once again and discuss with them of everything that they have heard so far, so that things becomes easier for them next time. Inconsistent between team members in communicating prognosis to families. So now this happens in such a situation where physician A says good prognosis, physician B says poor prognosis, physician C says intermediate prognosis. And the morning duty sister believes in B, the afternoon duty sister believes in C, night duty sister believes in A. And each of them communicate with the patient's relatives at 3 different times of the hour based on their perception. That causes the problem. So whenever there is such a case, when the prognosis has been explained differently by the different physicians, either nurses can discuss it among themselves and tell one thing, or they can encourage the patient's relatives to discuss with their primary physician at the earliest available opportunity and get a first-hand information rather than trying to. Yes, Dr. Dongre, this is also a very unique situation. I think you also have experience. As a CEO, you must have come across such problems that the same patient, same disease being prognosticated differently by different physicians. And
yeah,
yes,
yeah, it happens many a times, and may not be the same patient. Where there are 2 patients, the surgeon has seen, or you might have seen 2 patients. You just forgot which relative you are talking to. Say one with fracture, RTA, and other who is just recovering from respiratory failure. So in both the cases, when you fail to understand, every day you come across new relatives, or maybe in both the relatives are exchanged. So you must be in guard on that
very
point.
True, very true. Sometimes there can be 2 patients with the same name. So that also can cause problem.
And this has caused a big blunder as well in the history of ICU or in operation theaters. You can see same name but different blood groups, both hysterectomies. Yes, and many a times you might have heard that they will have exchanged of bloods. So someone who is A positive gets O positive, and the O positive gets A positive blood. So this is again a blunder which goes as far as the communication or written communication is very important.
Absolutely.
That this patient of this OT and under this consultant is also very important to get through all the written notes over there.
Therefore, you should be particularly careful when you have two patients with similar names and relatives of those patients are coming to you. You should check that if there are two Rajesh and he says that we are attendant of Rajesh, that which Rajesh, what is his full name? And sometimes the full name may be also same, Rajesh Kumar, both may be Rajesh Kumar. Then you have to again go forward and check that which place does he belong to. So likewise, you should not mistake. Surgery and ICU teams rarely discuss prognosis, but get angry when nurses discuss it. So these are some of the practical problems which everyone needs to work upon and overcome. And of course, difficult personalities in healthcare. Now, more importantly, in ICU, one important decision that is often one had to take is the end of life care. We all know about end of life care, and there will be separate classes on that end of life care also. We are not going to discuss it here. But there are certain barriers which are specific to end of life care decision also. Only a small window when can offer end of life care, and that also when the prognosis is often uncertain. So many a times, patient is not involved, or the patient's relatives are not involved in the discussions. We have seen, I have cited you the studies, the European studies, 95% of the patients' attendants were not in a position to take decisions about end of life because of their advanced disease. And only less than 68% or 20% of the patients, it was possible to discuss them. So these are very important situations in end of life decision when you are going to disclose the patient that we are not going to do anything active in this patient. We are limiting treatment. We are making his exit peaceful. We are allowing him to die peacefully without experience any pain, discomfort, fear, etc., etc. How the family is going to take it? How the family is going to accept that this patient is not being treated actively despite having a disease? That every nurse needs to know, needs to ascertain in their own way, needs to perceive it by putting themselves in patient's relative position at some point of the time, because then only they can get the best experience or the best learning experience to cope with such situations. Inability to acknowledge an end of life situations because of false hopes. Somebody has said that no, still in 5% of the patients still work. Patients' relatives may still that 5%. I can be within that 5%. No, these are all high hopes, false hope, extra hope, whatever it is. It is not a sin to be hopeful. But when patients have such expectations, you need to modulate your communication or conversation to a way that patient realizes that he may not fit it into the lucky 5% as well. So these are some of the things which are very specific to end of life care. Other two important aspects of end of life care. Yes, Dr. Anand. Yes, sir.
Yeah, just one point here I would like to add is that these patients are on ventilators, and there is a monitor which is going on, which shows some of ECG rhythm, some heart rate, some SpO2. And at that point, nurses are the best persons, and often they are being asked these questions, whether we are taking a right decision or a wrong decision. And you have to tell them, you have to make them understand that mere running of heart, which is there, is not an indicative of whatever we explained to you. So this is one important point, and you must understand that never give any false hope at this point of time. Otherwise, the situation goes difficult for a physician to go ahead and explain them about their end of life things.
Absolutely. I think he is very right.
Yes, sir.
That sometimes patients have a feeling that, okay, heart is still performing, the rate is all right. Patient may be vegetative, patient may be brain dead, may be severely vegetative of brain damage, hypoxic encephalopathy, but heart is all right, blood pressure is normal. So in that time, one has to be very careful. You have to prognosticate as nurses that yes, as far as heart is concerned, there is nothing. But as far as brain is concerned, nothing is allowed. So this side of communication. And another important aspect is that which we had seen among the young trainees, and that somehow during this situation, let my duty get over. And in my duty, let me explain that things are okay. Whatever next happens, my next the duty the resident who is coming will take charge, will try to. So never do such mistakes. If it is bad, it is going to create a very bad impact, or your colleague is going to bear that brunt. If the patient is not doing fine, if the prognosis is poor, if it is such that patient might die anytime, but you're within the next 6 hours, and your duty gets over within 1 hour, and you have given very high dose of inotropes and BP is now stable, but again likely to come down after an hour or two, don't try to give an impression to the patient that things are working fine and that they will improve with time, because in that case, you are not giving a false information, but you are in fact betraying your colleague by giving some wrong information or the wrong way of communicating information to the patient. So this is also a very important. Now, what is the role, if you know that, of simulation teaching in communication? You know, simulation means trying to create an environment. Whenever we create an environment of such a situation, imaginary, we are creating something which is reflecting or resembling a real-time situation, like that situation that you may having, like a patient's relatives talking to you about that the heart and urine being normal, respiration being normal, despite the patient's brain being damaged, following hypoxia, hypoxic ischemic encephalopathy. Now, if you can create such a situation by simulation and engage the nurses, engage your junior staff, how to communicate, then that is a very good learning experience. And that system of training is adopted in most parts of the world. So this is called CRM. CRM means crisis resource management. So crisis resource management, patient stimulation, like a patient, suddenly a healthy patient has a MI or a stroke or a heart attack, which is very common in the post-COVID nowadays. That day, someone in my family, very young, had a stroke, who has no risk factors only at the age of 41. So such things happen. So crisis resource management oriented training, patient simulation training, what it does, it engages the staff intermittently into such levels of training in communication that today you create suddenly a situation and you tell them, yes, you communicate. So that enables them to develop those skills in which they are lacking. Quality improvement initiatives have involved implementing physician-led. Now, you know, physician rounds are the rounds in which the nurses have to give a lot of inputs. Sometimes they give, sometimes they don't give because they're not asked. Sometimes they don't give because some physicians don't like. But whatever it may be, a quality improvement initiatives always wants that whenever multidisciplinary rounds occurs, the nurses should give their maximum input. In fact, at many places, it is a custom that the case presentation is done by the nurses and the residents are only joining when it comes to the time of interfering on the investigation results or trying to binge upon the differential diagnosis. And finally, the consultant takes a call based upon both. So this crisis resource management oriented training and quality improvement initiatives, both involving simulation techniques, are the most useful means by which training in communication can be imparted to the nursing staff. So the next question is how to elicit information for successful communication. Now, or when you elicit information as a nurse, when you talk for the first time or and the patient comes, always try to elicit the main problems which is concerning the patient. What are the perceptions of the patient? What are the physical, emotional, and social impact of these problems on the patient and his family? Now, once you can elicit it nicely, easily, then your other tasks become easier. Because after that, what you need is used to tailor your information to the patient on what he wants to know after checking his skill or his understanding abilities. Also, try to determine how much the patient wants to participate in decision making, because we often see patients says that you are the best judge or my physician is the best judge. हम क्या बोलेंगे, हमें इस बारे में हमें नहीं knowledge, आपको जो ठीक लगता है डॉक्टर साहब आप वही करिए. So when the patient, how much, or it may be to the other extent that patient wants to know every inch or every bit of it, observe the patient's reactions to the informations that you are conveying to address his concerns. Because if you are conveying, patient is not gulping those informations or assimilating those informations, then you should not move to the next information. So these are some things which you learn gradually over training. So what are the common mistakes which are made during patient counseling? Yes, the Dr. Dongre, you want to add something?
Yeah, just to add to this,
Should I go back
information.
To this
No
slide?
issue. Yeah. See, just eliciting information, this is for all matrons who are sitting here, that they can go for a simulating exercise every day in the morning, just before the rounds begin. This is for all communicable patients, either in ICU and especially in COVID era, you will find that there are many communicable patients in ICU as well, those requiring intermittent BiPAP. So whenever you take hands off, ask your sister to ask 3 or 4 questions. I call them 7 golden questions to be asked in the morning when you meet the patient for the first time. You must ask him, how are you? Good morning, sir. Because that is the way you start having a rapport with your patients. Once the rapport is established, you tell that I am Shivangi or I am Ashwini. I am with you till 2 o'clock, say morning duty, and then I'll be at your service. First, you must think yourself that your patients are guests and they are giving you an opportunity to put an even IV line. So you must pay their respect. And with that respect, you can start asking questions. And 3-4 questions, you can screen the entire body of that patient, that whether he has taken a breakfast, whether he has have a good night's sleep, and whether he is having any pain or is there any other problem. These 4 questions tells you everything, that what is the problem with the patient. And when the round starts with the consultant, you can just communicate with the consultant that this is the problem. This just takes 2 minutes. Sir,
very good point. Dr. Anand has told how to build up rapport in 4 or 5 questions. So what are the common mistakes which we make during patient counseling? One, you try to advise and reassure before identifying the problem. You don't know what is the main problem that is causing him that anxiety or giving him that tension. It may not be his, it may be because he is uncomfortable wearing something is hurting him on the back. So, sab kuch theek hai, theek ho jayega, don't worry, aapka heart. It may be that something is pinching him on his back or some nail are pinching him from his bed. Rejecting their distress as normal. If patients relatives express distressing that how come this has happened, that I am feeling bad, you don't reject that distress as normal. Attending only to physical aspects, ignoring the emotional or the intellectual aspects, that is also a mistake. A patient is not happy if his only physical concerns are looked upon and other concerns are rejected or are ignored. Switching the topic. If your patient wants to topic, you want to avoid the topic. You want, acha, theek hai, aap bataiye, kal ka match kya hua? These are something which patient wants to know. So whatever possible, to the best possible ability, try to give him that answer. And jollying patients. Jollying patients along means, sometimes it so happens, we have seen, that, you need not worry, after all, your son is a famous builder of the city, he will do something. No, this is not the time to make patients feel that of those importance. So you should not try to, of course you should try to encourage them to say it, smile, to make them mobile, etc. But don't try to make them or ridicule some of their देखिए इतना पैसा था फिर भी तो कुछ नहीं हुआ. So all those things should not be. What makes the patient apprehensive? If the patients find that you are demonstrating lack of competence. Lack of competence is that, see, I can't say much. Your patient, you are Dr. Dr. Anand's patient, probably he will come and he will take it. So patients, this is something makes the patient apprehensive. Disagreement on treatment options with colleagues. I think we should operate now. There is no time to waste, but he is saying surgery is risk. So don't try to, these discussions make patient apprehensive, although nurses don't have much role here, but they should know what makes the patient apprehensive. Criticism of colleagues. Surgery, this complication has occurred. Who was the surgeon? Mr. X, Dr. X. So these are something very bad. Be pessimistic. I am sure this patient is going to develop complication now. After within a year, going to be in shock. Or raise patient's anxiety by asking such tips. Don't run the drip fast. If this adrenaline goes at this rate, next you will be cardiac arrest. If this improves, we will get hyper. So these are something which patient, if he is hearing, listening, and is able to comprehend, and these words can make him apprehensive. Now, what are the techniques for allaying apprehension in difficult patients? Not all patients are easy patients. There are a lot of difficult patients. There are a lot of patients who are inherently very inquisitive in their mind, or who don't try to understand with logic, or who want to be that the same thing be told several times. Always remember, establish eye contact with the patient from the beginning. If you don't establish eye contact, that gives you also the confidence and makes the patient, helps you to bring the patient closer to you. Always encourage patients to be exact in the sequence in which the problem occurred. Key dates: first patient had a headache, then patient developed fever. Fever was 5 days back, headache was 7 days back. So in exact sequence. Use active listening to clarify what they are concerned about in the ICU. Whether they're concerned about their respiratory problem, whether they're considered about their headache, whether they're concerned about their pain abdomen. Give an active listening. Avoid interruptions when they have not completed their sentence. Let them complete their sentence. Don't after that. And after you have heard them, summarize all their information in your own way and narrate it to the patient, because that will give them the confidence. That will make them understand that, yes, this person has heard me in ICU. He has listened to whatever I say. So if you can do that, that will allay apprehension even in difficult patients, because they will become convinced that you are listening. Now, what ways it can be made more meaningful? You can make this communication more meaningful. Check what they consider as wrong. I used to take this medicines, and so probably this was the cause, and this is how this has developed. My cancer is developed. No. So you check what they consider as wrong and how these beliefs matter in their care. Prioritize their information so that important ones are dealt first. Check all that the patient have understood while moving on. It has happened with me because some patient had told me that they were on statin. So someone had told them that statin causes muscle weakness, and because of that muscle weakness, their prostate problem. No, this has got no meaning, but this meaning has been conveyed to him, or he has acquired that meaning during this entire process of journey from the OPD to the ICU. If complex illnesses or treatments, check if the patient needs any additional information. Patients might need some more information to what you think is adequate. It may not be adequate for the patient. Now, what are the ways by which you can win confidence during conversation or counseling in your ICU? Show that you have some sense or how he or she is feeling. If the patient is feeling bad, you are understanding, you are acknowledging that you know that patient is feeling bad and you are sorry for them. Give them some feedback about your intuitions that, yeah, I know that I also experienced a similar situation when my brother was sick, and I know how you can feel. Make some educated guesses that I think you are concerned of this. You are worried more because your son has still not reached the city. He is staying abroad. Even if your guess is incorrect, that no, I am not worried about my son. I am worried that my daughter is stuck in there. Even if your guess is incorrect, it shows that you are trying to understand their problem. So if you can make them understand that you are concerned about that problem, then you can gain confidence. Now, how to teach this communication skills to your junior staff, those who are working with you? Provide examples to your juniors of their deficiencies in their current mode of communication, reasons therein, and the consequences thereof. Whenever they are conversing, you stand beside, listen, or you indirectly stay a bit away and listen. And later on, call them to your side and say that while talking, you were telling this thing. Now you see what happens, what the patient thinks. And when something that this demonstrates skills needed to overcome these deficiencies, give them an opportunity to practice those skills under controlled and safe conditions. Controlled and safe condition means comparatively healthy patients or comparatively healthy situation where things may not get bad if it is not done properly. And give feedback on their performance and reflect their reason. Because unless your junior staff are trained in communication skills, it may give you a lot of stress, which you have to cope up with unnecessarily. How can trainers demonstrate the key skills in action? Sometimes this is, of course, in abroad, they show videotapes and audio tapes of real consultations and discuss their impact in simulation-based training. They use interactive demonstration by modeling in a simulated patients, allow constructive criticism by the trainees, asking the trainees to reflect what they have learned, and highlighting any blocking behavior. Blocking behavior means if you are dragging a conversation to another extent, which is not anyway related to, if a patient has come to you and is trying to discuss with you about his stent, what are the chances of stent getting blocked, etc., etc. Suddenly you notice something, Sachin Tendulkar's shot was very poor. So something, these are called blocking behavior. So this should be highlighted. So in any intubated patient, so this chart I will try because this shows that how you, if you have an algorithm, it becomes easy in any ventilated patient. Because the ventilated patient, someone asking me in the beginning, I think Vinny D'Souza, that how to do in ventilated patients. In any ventilated patient, if the patient's level of consciousness adequate or not, that you have to check first. That is, there is some score known as the Richmond agitation sedation scale. So for your RAS score, if it is more than something, then no. If it is yes, then another. Provide primary and supportive therapy. Forget about communication. If it is less than 3, if it is no, then you check for patient's cognition level. So level of consciousness is 1. Next is cognition level. Cognition level is adequate or not, we can know it from the CAM ICU. That is again another mode of screening. If you know it is good, if you don't know, then also it is, you can know it all this. But you have to know that level of consciousness, if it is adequate, then you have to assess the patient's cognition level. So for consciousness, adequacy of consciousness, there is one type of test. For adequacy of cognition level, there is another type of test. Then we have to evaluate for auditory acuity, visual acuity, language. And then you assess the functional skills. What are the patient's fine motor abilities intact? Yes. If the patient's fine motor abilities are no, not intact, then you have to that if yes, if no, if yes, then you see what are the patient's gross motor abilities intact. First fine motor abilities, then gross motor abilities. If no, you use communication board. There are certain computerized vocabulary methods. I'm not going into that. If the yes, then you see if the patient can write. If patient can write, give him a pen and paper. He will be able to. Then you assess and document the effectiveness. If the patient's gross motor abilities are there, or if it is not there, you see or gaze or eye blink. So a lot of things you can ask your patient to check if they can blink and give their response. We have seen it very often. Again, with the motor abilities intact, you check, does the patient have a tracheostomy or not? Or if yes, are the patient's laryngeal structures intact? If yes, can the patient tolerate cough deflation? If yes, try a one-way speaking valve. If no, does the patient have tenacious or copious secretions? If no, giving a speaking tracheostomy tube. If yes, then discuss about the electrolytic. So there is a stepwise approach to understand how to communicate a ventilated patient. So that is why this chart is very useful. That is why you can use this algorithm also. Now I want to also to assess this study because nurses experienced more difficulties in communicating with patients and their families and families and their caregivers than performing essential nursing activities. Now, this is something very important. Published in BMC Nursing in BMC. What does BMC means? British Medical Council? No. BMC means Biomed Central. That is the name of the journal. So whatever it is, their routine performing essential nursing activities is easier than communicating. But more importantly, they found that the nurses recognized that they could address these difficulties by improving their communication skills over time through experience and learning. So this is a very important lesson that this research has brought forward into the limelight. So in order to impart communication skill training to the nurses, particular to the ICU nurses, there are various formats. We have seen that this is 3 workshops. Session 1 on certain role play on algorithm, scenario on mechanical ventilation via endotracheal tube, role play on suctioning procedure, alphabet board, word phrase, because many a times patients cannot speak full sentences, particularly patients who are recovering from stroke neurologically, who have speech impaired. They can share it in half response, how to extract information from them. So there are various plans upon which communication skills workshop should be developed. And it is very important for the ICU leaders to take lead in organizing such workshops for the critical care nurses in their hospital, in their cities, in their towns, so that application of augmentative and alternative communication devices can be arranged, because these devices can be used successfully and they can extract a lot of information from patients who are moribund, who are otherwise incapable of giving you the information that is important. And all of this can improve the nurse-patient communication. Most studies have shown that there is need for intervention to assess nurses' perceptions and experiences regarding nurse-patient communication. There is a need to judge whether nurses' competence is improved after imparting them communication skill training. That is very important. Assist the junior nurses during communication with difficult patients. All cannot handle difficult patients equally. But if they are guided during their formative period, during their initial training period, they can become experts and incorporate useful communication strategies in their curriculum and in-service education programs, so that they can continuously nurture. Like Dr. Dogre said, the matrons, many of the matrons, because of their lack of practice, their communication skills can deteriorate over time, because they're not doing night duties. They're only doing administrative during the day at many places, not always, not everywhere. So my take-home message would be, effective communication can make a patient's ICU stay less stressful, not just for the patients and their relatives, but also for the doctors, nurses, and the entire ICU team. It improves their mental and psychological well-being and facilitates recovery. It is well known, well understood, and well appreciated also, and proven scientifically that if mental and psychological well-being can be taken care of, recovery is facilitated or expedited much more easily. Methods of improving communication should be discussed among the full ICU team, all team members, not the ICU head, the second in command, the senior residents, the junior residents, the sister in charge nurses, everyone, because its improvement is necessary for one and all. Good inter-staff communication can help to relieve a lot of stress. Already a lot of us are so much of stress because of COVID. And if there is poor communication and the effects of fallouts of poor communication are run, then definitely it will affect your physical health and your mental health. Many unnecessary confrontations can be avoided, and we can focus on our work and achieve our goals with much more perfection if communication is properly attended. So good communication skills are second to none. When as a speaker, when as a listener. When as a speaker, use a good speaking volume, not too loud, not too soft. Pronounce words clearly, take turns, look at the listener, answer his questions. When you are listening, look at the speaker. I told you, eye contact is very important. Use a good speaking rate again, not too fast, not too slow. Listen carefully, ask questions whenever you need to. Good communication skills are the real key to success. And believe me, if your communication skills are poor, you can never be good. In presence of good communication skills, you can be good or bad. But if your communication skills are poor, you will definitely have a bad effect. I will now take the questions because I have finished my thing, and I will also ask Dr. Dogre to illustrate on the last part because I think he was.
Yeah, just thank you, Dr. Anirban, for a nice lecture on this communication skills. But I think most important is in ICU, especially somebody is on ventilator, and you must consider that he is not a patient, he is a human being. He has got a life who cannot react, but he understands the things. That the key to success, that whenever you during the hands-off or handover, when you take patients on with you, then you must communicate with the patient, go near him, hold his hand, and try to communicate some syllable words that yes, Mr. So-and-so, you are here, you are okay, you are fine, you are breathing well, you are on ventilator, that machine is giving you this. At least some communication you establish, whether they are listening or they are in communication with you or not. But as long as the brain is listening, I mean, I'm not talking of those patients who are having intracerebral hematoma, large infarct, or their initial brain functioning is not working. Not those patients, especially patients of pneumonia who are on ventilator, who have been sedated, and you can always communicate with them. Never think that the brain is lying down without any communication skills. Number one. Number two, have a clarity that you are dealing with the human beings. So 5 C's are very important: clarity, consistency, creativity. Creativity, again, you need to know the sign languages so that you can understand what patient is trying to communicate to you, especially those on a ventilator or those with a tracheostomy, they are unable to communicate to you. And content, you must know what is the file showing, what sort of disease is there. So you must at least know that this sort of disease demands this sort of treatment or requirement of communication. And then you can communicate them, or you can connect to them very well.
Yes,
further, I think it is very well summarized. Any questions are there? You can directly ask.
There are questions. No, there are questions. There are questions,
and you can ask questions.
There are questions. I am going through the questions. One is Sagar Bhubare has said that, sir, language is one of the barrier for good communication. Yes, Sagar, language is one of the barrier for good communication. But as I have told before, that verbal and non-verbal communication both are important. So by your non-verbal means, by your look, by your touch, by your eyes, you can communicate with the patient that you are caring. And you can take help from some of his relatives. If everyone is not understanding Hindi, at least some of his relatives. So take his help. Take the help of other people who are among his relatives, who is familiar with the language in which you speak, to understand what is his problem and communicate in that language. The patients can feel that you are caring for them if you do that. So you can overcome that. From Shani Janu, as a staff nurse is there any limitation to communicate with relative? For example, if they ask about the patient's investigation, what should we do? No, not at all. Not at all, Shani. There is no limitation to communicate. In fact, communication is encouraged. to you with examples. But you should not communicate about things that you honestly think you are not aware of or you don't know. There is a patients who have been asked for any particularly investigation. Then what is the importance of doing an angiography at this stage? So that part you should not give your comments. Yes, the doctor has advised you angiography, and angiography is done to detect some blockage in the vessels. And probably you have some blockage in the vessels based upon the symptoms which you are experiencing. The doctor has advised you and this. But what would be the value? What should be the supply? How much that investigation would reveal a defect, or it may not, or it might lead to, or it might need for a surgery. Don't comment on that, because that is not within your domain. So you have to communicate, you must communicate, you are encouraged to communicate, but only upon the condition of the patients in which you honestly can give an opinion.
For a simple example, I gave you that most often in ICU you come across with the patient that you look at the bag, urine bag, I meant to say, and you find that there is hematuria or the color is red. So you can always tell that he is having hematuria. So he will understand. Your physician or your consultant will understand what to do next. Or say a patient is having on AKT or not. So you can understand whether this is hematuria or this is just red color. These are the points which one should always be in communication with your consultant who is giving rounds.
Very true. Ashanjali is asking, how can we effectively communicate? How can we have effective communication among various departments in the hospital, especially by new joiners and junior staffs in the deep school? Well, Ashanjali, you or your ICU head has to work upon how to have an effective communication between the various departments, so that they can discuss, they can take part in the rounds, they can take part in the clinical meetings, give their opinions and give their feedbacks, the strategies. So this is very much individualistic. Whether you can have the various departments of the hospital, means a biochemistry department coming in, that may not be necessary, but at least the clinical departments of relevance, they should be taking part, the physiotherapists, the infection control nurses, because many a time infection control nurses are coming at an interval of say 15 days, 1 month, by which time some staff changes, they're not able to identify, they're not keeping a track of their previous, so something. So probably that the ICU head or the director of the ICU, they should plan it, and the hospital should plan it. That is an administrative decision. But yes, it is very important that such joint rounds be taken of a periodic frequency, and with the objective that there should not be any communication breach between allied specialties. Don't you think, Anand sir?
Yeah, exactly what problem she had with the communicating with other departments. Are their consultant not willing to come to ICU, or
no, she's saying that they're busy. She's saying that the junior staff, they're busy in their busy schedule. How to affect
right.
So
right. As you said, it will be an admin problem
that is
than the ICU problem. But again, I tell you that many consultants who are visiting ICU, and you know that he is from the same hospital, and make sure that every staff nurse on duty knows that consultant, and whenever someone enters the ICU, at least you should say good morning, and you should try to communicate with him and show him some respect. I think then all juniors, whatever junior or senior, they will try to come to ICU very often.
Yes, and you should not feel hesitant in communicating. If the microbiologist is coming for rounds to check the infection control process, and you should not feel hesitant. You can always ask and discuss with her, and also try to gain important informations, because that might be helpful. There is one question from, I don't know, this is not his real name. It is Realme 6. So Realme 6 must be a pseudonym, not a real name of the question or the asking the question. As an ICU in charge, how I teach my staff for good communication. I have already narrated you that various modes are available. The easiest one is to collect feedback from the patients in the form of questionnaire. Then there are tools available. Then there are simultaneous simulation-based techniques. So one and all you can use, but whichever you use, you must use the same thing for a sufficient number of time rather than switching from one method to another. So you can use all the methods simultaneously over a period of time and then assess, or you can pick and choose one of the methods. This is the non-technical skills. The notches S method is there that has been, yes, validated for ICU. Anand sir?
Yeah, if you are really interested in doing that, which I have been doing for a long time, that after the rounds, if there is a space available away from the patients, you can just stimulate a disease every day, a chest specific disease, abdominal disease, surgical disease. You can name that disease and start teaching your staff what should we do whenever this sort of patient comes. And you can ask in person for the whole staff to do or delegate their jobs and do it. Like as in CPR, we are made to understand that there are 5 members and 1 member will do this, other member will do that. The same thing has to be done. You delegate the job, and then whenever the patient comes, say in hypoxic situation and in respiratory failure, everybody is in dilemma what to do. That situation should not arise whenever there is a crash in your ICU. And for cold rounds, yes, you can always teach them. After the rounds, you can take them to a separate corner and tell them every day one case study or case report or whatever case simulation you can do.
Very good idea from Dr. Anand. And also, you see, these trainings are becoming more scientific now. So you can always try simulation-based training, because that will help in achieving your objectives within a very short time. Within a short time, people will get trained.